Hello, everyone. Welcome. How's the volume? It's okay? Really nice to see everyone here. My name's Denise Vigno. I'm with Development and Communications at Howard Center, and this is a really nice turnout for our first event. The Community Education Series is a new program that we're offering. We're very excited about it. Understanding Opioid Addiction is the first in a series of 3 this fall. So I have a couple of housekeeping items and a few thank yous. Obviously, everyone knows that we're ushering people back and forth. That was part of our arrangement with Dealer.com. Beautiful building, isn't it? There's also a tennis court. We didn't take you that way. The same, if anyone needs to leave early, people will guide you back to the lobby area. And then also restrooms are right around the corner. People will guide you there as well. Thank yous. There are many. Dealer.com and their staff have been amazing and offered to generously host us. VCAM staff, Bill, Tyler, and Seth, are videoing tonight so that we will be on our Howard Center YouTube channel and our website in weeks to come. So that will increase impact. Send your friends, family, and colleagues there to take a look. Also, thanks to our Howard Center IT staff, Russ and Rob, for giving us a hand, and also to United Way and all of our community partners for promoting tonight's event. And then also to our community volunteers who are ushering all of you. So without further ado, I would like to introduce tonight's presenters, Dana Poverman and Dr. John Brooklyn. Dana here, Dr. John Brooklyn. Dana is a licensed alcohol and drug counselor and a licensed clinical mental health counselor with over 25 years of experience in the mental health and substance use field. She's managed outpatient, school-based, and community programs over the years and is currently the director of Howard Center's medication-assisted treatment program. Dr. Brooklyn has 23 years of experience in the field and is currently the medical director of Howard Center's Chittenden Clinic. He's also a staff physician at the Community Health Centers of Burlington, medical director of opiate treatment programs in the Northeast Kingdom, and clinical assistant professor of family medicine and psychiatry at UVM College of Medicine. He also consults with various organizations. So thank you both for being here. Welcome.
Thanks, Denise. And I think on behalf of everybody at Howard Center, I can say we are very excited to see so many people here. This is a new venture for us, and it's really wonderful to be able to provide opportunities for people in the community to learn more about what it is that we do. So this, can everybody hear me okay? Okay, just wave if it gets soft. Tonight, Dr. Brooklyn and I are going to attempt to give you a very broad brush understanding of opioid addiction. We're going to be talking about what are the biological, psychological, social, and existential aspects of this disorder. It's very complicated. So we're going to be trying to do this within an hour, and I forgot to start the timer. So Denise, can you give me I'm going to speak for attempt to keep myself to 20 minutes, turn it over to John for about a half an hour, and then come back together to talk about what treatment options are available and what's been happening in Vermont over the last couple of years. So while we're focusing tonight on opioid addiction, I do want to mention that drugs of choice sort of come and go in and out of vogue. We happen in Vermont and in the Northeast right now to be having a real surge of an opioid epidemic. It was a couple of, almost 2 years ago, that our governor dedicated the whole State of the State address to this complicated situation, and really it is truly an epidemic. When I started in this business 26 actually years ago, cocaine was more the big, bad kid drug. Alcohol was most prevalent, seconded by marijuana. But in terms of the hard drugs, it was really cocaine. And then in about the year approximately 2000, we started seeing a real increase in prescription pain medication abuse. And that corresponded approximately to the time that Oxycodone, under the trade name Oxycontin, was promoted as a less addictive, a non-addictive kind of medication to treat pain. Well, lo and behold, come to find out, not the case. And over the course of the last 15 years, we've seen the cost of those prescription medications on the street go up. And so a vacuum's been created, heroin's come in, it's much cheaper. So here we are today, and we're going to try to begin to share with you a little bit about what it's like to live with an addiction, what predisposes, or what are some of the risk factors, and what are we doing about it. So I thought about, how do I try to convey to people what does it mean to have an addiction? And I thought, really, it's hell. I mean, it's like being in hell. So I searched the internet for some slides, and I found this illustration. This is Dante's third circle of hell, which is gluttony. Of the 7 deadly sins, this one's gluttony. And for those of you who know me well, this is where I will be going because of my cake lust. So, but I think I show this slide for 2 reasons. One is that I think it depicts very vividly the kind of torture. These people, they're called shades in Dante's poem, epic poem. So these are the ghosts, and where they are stuck in this level of hell, and they're in a slush that they just can't get out of. What's also interesting is that gluttony, it applies not just to food, but all kinds of addictive, compulsive, overuse behavior. What this sort of reflects is that our society as a whole has had a very moralistic approach to looking at addiction, and seen it primarily as a condition in which people, because of lack of moral capability, lack of self-will, end up in a situation of their own making. So I hope when you leave here tonight, you're going to have a slightly, hopefully more than slightly different perspective on that. Let's see. So the work we do in the field of mental health and substance abuse, we're guided by a manual, the Diagnostic and Statistical Manual of Mental Disorders. And what this tome attempts to do is to put together clusters of symptoms to try to define what a disorder is. So these slides are all in your handouts, so we don't need to read it out loud here together, but I want to point out in the first bullet a number of the pieces of this puzzle, that it's a cluster of cognitive, behavioral, and psychological symptoms that, in spite of, so anyway, this focus on that, I'll come back to that in a minute. And then the second bullet is that it talks about how important it is to understand that the nature of this disorder also includes some underlying changes in brain circuits, so that even in spite of consequences, the people will continue to use. I've included the criteria that we use when we are trying to make an evaluation of whether or not, an assessment of whether or not somebody indeed has an opioid use disorder. So there are central features to addiction. One realm, one area talks about impaired control or compulsion. Another area that we look at is how that's affected social functioning. Another aspect that we look at is risky use. And then interestingly, in this 5th edition of the DSM, the pharmacological aspects of this disease, if you will, are put last. And in the 4th previous edition, it was very interesting, the first 2 criteria for what was then called substance use dependence had to do with tolerance and withdrawal. And what we I want to differentiate for folks today is to understand that there is a difference between when our bodies accommodate or try to reach some kind of homeostasis when we put a substance into it. So that any of us here who is prescribed opioid medication over a period of time is going to develop somewhat of a tolerance, meaning we get used to what those effects are. Our body tries to adapt, to go back to what's the norm. And so when we come off of those medications, if we have a responsible physician, we're titrated off slowly so we don't experience any withdrawal. So the big distinction here is that somebody who's developed a tolerance to a substance does not necessarily have an addiction. This is one piece of it. The whole other piece that's really important to understand, there is a pattern of behavior and a pattern of thinking that is not helpful to the individual any longer and that a person continues to use despite consequences. When Denise and I early on were talking about this evening and how do you in an hour and a half teach people or convey to people what does it mean to have an addiction, I was really personally keen on showing a film that's been out for I think it's a couple of years now, called The Hungry Heart. That's the story of a pediatrician who's now retired, Fred Holmes, who practiced in St. Albans. And he had, as a pediatrician, been treating children in the context of their families from birth till they aged out and moved on, wouldn't see them anymore because they were too embarrassed. What he found over time was these children that he had known forever had developed addictions to opioids, and he felt that he wasn't prepared, he didn't know how to treat it. So over time he became trained, and he's really, in my mind, one of the heroes that has been out there in terms of how to work with people and how to work with kids. I really encourage you to see this film because I think it will say a lot more than the words that either John or I is able to share tonight, that depicts the stories of a number of the kids that he's worked with, and it's very, very poignant. And I think you really learn more about the heart and soul of addiction by watching that. Do we have copies of that, Denise, for people to borrow? We do. Yeah, so I got vetoed because it was too long. So instead, you get to listen to me. Another image that I think is really powerful in terms of describing addiction is one of the hungry ghosts. The hungry ghosts are, and I plagiarized this analogy from an author, a physician named Gabor Mate, who practices in Vancouver and has treated people with addictions. And in the Buddhist tradition, there's a cycle of life. And one of those cycles of life is the hungry ghost. The hungry ghost represents a state of being that can never be complete. It is never satisfied. They're characterized by these very, you see in the picture, these emaciated arms and very bloated bellies, and they eat and eat and eat, and they're never satisfied. And the metaphor that Mate uses is that addiction is much like that essentially, at its essence, there is an emptiness, a pain that just cannot be filled. And in fact, I'd like to take a moment just to read an excerpt from his book, which I also would recommend, In the Realm of Hungry Ghosts. He tells stories about the patients he's worked with, and as many years as I've worked in this field, I found that it renewed my compassion. It renewed my commitment to doing this work, even though it's very, very difficult work. So he writes that the inhabitants of the hungry ghost realm are depicted as creatures with scrawny necks, small mouths, emaciated limbs, and large, bloated, empty bellies. This is the domain of addiction, where we constantly seek something outside ourselves to curb an insatiable yearning for relief or fulfillment. The aching emptiness is perpetual because the substances, objects, or pursuits we hope will soothe it are not what we really need. We don't know what we need. And so long as we stay in the hungry ghost mode, we will never know. We haunt our lives without being fully present. And at this point, I found this little clip, and I'd like Denise to get it going so you can see it.
All the substances of abuse, whether they're opiates or cocaine or anything else, they're actually painkillers. Some of them specifically are painkillers. But physical pain and emotional pain, the suffering is experienced in the same part of the brain. So when people suffer emotional rejection, the same part of the brain will light up as if you stuck them with a knife. The Eckhart Tolle says very nicely that addictions begin with pain and end with pain. So that all the addictions are attempts to soothe the pain. So when I work with addictions, the first question is always not why the addiction, but why the pain. And what you find is emotional loss or trauma. In the case of the severe addicts, as in the downtown East Side here, they were every single one of them traumatized. There's no women walking the streets here who had not been sexually abused, not even by accident. But you know, whether it's a sex addiction or internet or relationship or shopping or work addiction, these are all attempts to get away from distress. Keith Richards, the Rolling Stone guitarist, said, who used to have a severe heroin habit, as you know, he said that all the contortions we go through just not to be ourselves for a few hours. Or why would somebody not want to be themselves? Because they're in too much distress and too much pain. So I don't care what they tell you about genetics or any of that choices or any of that nonsense. It's always about pain. Well, the Tibetan Book of Living and Dying, it's got a wonderful line in it. Whatever you do, don't try and escape from your pain, but be with it. Because the attempt to escape from pain is what creates more pain. And that's the reality with addiction. But the question is, how can people be with their pain? Well, only if they sense some compassion from somebody. So as another teacher says, only when compassion is present will people allow themselves to see the truth. So addicted people need a compassionate present which will permit them to experience their pain without having to run away from it. And all the attempts to run away, it's like another teacher says, the surest way to go to hell is to try to run away from hell. So you got to be with that pain. You just have to be with it, but you have to have some support. And we live in a society that, one way or the other, is always about instant relief, quick satisfaction, distraction. In other words, we live in a culture that is based on, both economically and psychologically, on not supporting people to be with themselves. So it's always the quick getaway. So it's very difficult to deal with addictions in a society. But yeah, it is a matter of, at some point, finding a way of being with your pain so that you can actually get to know what it's really all about.
I'm really struck by how little time there is to go into such a deep subject. One of the things that I wanted to talk about is to talk about what makes some people more vulnerable than others. Why do some people become addicted and others not? We look at a number of disorders, be they mental health disorders or even just physiological disorders, as a combination of stress and vulnerability. There's this new line of science called epigenetics, and it looks at what somebody's DNA may be and then what are the environmental conditions that turn that light on. So there certainly are some genetic markers for addiction. There are some other things that will affect a person's vulnerability. Thinking about the intrauterine environment, there are a number of assaults that can happen to a developing fetus that may make that person more vulnerable to some of the things in the environment. Early life attachment problems. Again, this is the whole other lecture unto itself, but the way we develop as human beings and how we first relate to those most important people in our lives helps us figure out how we're going to relate to the world. So if you're growing up in an environment where the parent can't be really present for you, can't hold you, can't respond to your cries, is maybe using substances themselves, or maybe there's domestic violence going on, that's not a safe developmental experience. Socioeconomic status is a factor. Poverty is stressful. Opportunities are fewer if you don't have education. In an impoverished environment, I think we would speak to not just the socioeconomic status, but do your parents read to you? Is there language spoken at home? Do you get to draw pictures? Some of those things that many of us take for granted don't always happen in a family life that's really chaotic. And you'll notice as you look at this slide that some of those variables that are in the vulnerability column are also in the stress column. So that people who have mental health issues will often try, there's the self-medication theory. We see very, very often in the substance abusing population, when we did some analysis of this when I was in our outpatient program at Pine Street Counseling, we wanted to see how frequently we were identifying the co-occurrence of both a mental health problem and a substance abuse problem. And this was not even in our opioid treatment program, which is a much more acute program. But we were finding about 70% of those people who are enrolled in our outpatient substance abuse programs also had a co-occurring mental health problem. Most often those are things such as anxiety, depression, stress-related disorders. Sometimes it's a full-blown post-traumatic stress disorder. Sometimes people don't meet the full criteria for post-traumatic stress because there may not be a single event, but growing up in an environment where abuse and neglect, domestic violence is the norm is certainly ongoing trauma. The other thing I'd like to add that we may not think about as much are some of the sociological factors that provide stress. So racism, all of the isms, homophobia, the kinds of prejudice and social stigmatization that people have to live with also make it more difficult to develop a sense of, I'm a good person, I'm okay, I like being who I am. And as we saw in the video clip, one of the things that Mate talks about is that emptiness and sense of self, or that feeling that I'm okay. The other flexible thing is modeling behavior. How are stressors dealt with in the family I grew up with? So those are some of the, I'm going over this very, very, very quickly, and we will do our best to save time for questions at the end. I'm going to turn it over to Dr. Brooklyn now to talk about, this part's fascinating. I just find this fascinating, the brain stuff that happens. And then I'll bring it back at the end to talk about treatment options, levels of care, what we can do to offer people, and what's been happening in Vermont, and then we'll move on to the question and answer. So thank you.
Dana, that was great. Thank you. I'm not sure I can top that. I don't know. So, you all have slides that I gave you, right? So if I don't read the slides, you'll be okay with that? Okay. Because I'm going to draw some pictures. I like to draw, and I have this great canvas here. So I'm going to do a little drawing and refer to some of the slides. So there's a slide here we're going to start with. So this is a picture of the brain, and I'm going to turn this on. It's on? It's good? Can you hear me? So the interesting thing about our brains is that we're really hardwired for novelty. If you think about why would we as humans do much of what we do, it's because we have this little orange section called the reward section of our brain that when we do something, a chemical called dopamine gets released, so we feel some kind of a response. So it's really involved with eating, sleeping, procreation, finding of shelter. All of those things are at the very base of all life. And so we have a fairly elaborate system for getting a signal that says, that feels pretty good when I do this. There's a theory that the reason, in addition to what Dr. Mate says, is that there are humans who are deficient in the way that the dopamine works in the brain, so that normal things that you and I might do that give us pleasure, they don't get a release of dopamine. And so they have this bit of ennui or lackadaisical response, so that when they take a substance, and it could be from chocolate to morphine, there's all kinds of things that humans can take that would cause dopamine to be released, they feel kind of a sense of reward and a sense of normalcy. And we estimate it's probably anywhere from 5 to 7% of humans have this genetic reduction in the amount of dopamine receptors, the amount of dopamine that they make. So if we think about the fact that this may be a brain disorder, there may be, we know that there are individuals that if they take a substance, whether it's, like I said, chocolate to morphine, they feel normal, then they're going to continue to do that because that gives them a sense of reward. The other part that's really interesting is that when you look at the pain fibers, the pain signal, it goes right close to where the reward mechanism is, and the memory center is close to that. So one of the theories is that when humans have pain and they don't have a normal mechanism for dealing with it, when they take a substance, it causes them to feel better. So in the brain, when it comes to opiates, there are these cells, and they're located throughout the brain. If you look at the memory center and the reward center, there are, at this, I don't know if you can see this well enough, there are a collection of cells that release this chemical called epinephrine. And epinephrine we release in response to stress. So on these cells are receptors for a chemical that we make called an endorphin. And an endorphin means internal opiate. So we make a endorphin, there we go. We make a chemical that binds here that stops the epinephrine from being released. So when we're having pain or we're having stress, we have a natural mechanism to make ourselves feel better. We have receptors for nicotine in the brain. We have receptors for marijuana in the brain. We have receptors for alcohol in the brain. So anytime you have a receptor, it means that if you take a drug that goes to that receptor, you're causing something to happen in the brain. And as Dana pointed out, this business of tolerance and withdrawal, people can become physically dependent, meaning that they take a substance that they take over and over again, and it changes the way that the brain responds. So we have a physical basis for why certain drugs people are more likely to use and keep using. Above us, we have this thing called this area of the brain, which is very rich in dopamine, called the ventral tegmental area. And essentially what happens is that if you take, and we can use the case of an opiate, if you take an opiate, and you are susceptible to getting a positive response, it's going to make you feel good, it's going to cause a signal in the ventral tegmental area that's going to send dopamine to the front part of the brain where we store our memory. And from there, another signal goes to the thinking part of our brain. So if you are walking down the street and you see something on the ground and you decide you're going to taste it, and you put it in your mouth and you get a really good response, you might think, okay, every time I see that thing on the ground, if I take it and I get a positive response, I'm going to do that over and over again. So we call this what's known as the hedonistic model, whereby if you experience a pleasurable response, you will try to replicate that over and over again. So the tricky thing about opiates is that they have been around for 10,000 years. I mean, opium is one of the oldest known substances to humanity. And so when we begin to think about the use of opioids, we can see that there are receptors for opiates, these opiate receptors, where the endorphins bind. In some individuals, when they take, whether it be a painkiller, we'll use that as an example, they may also experience a pleasurable sensation where dopamine gets released. And in these individuals, they are much more susceptible to developing an opiate use disorder. So about 92% of us in this room don't have this problem, because if we were to take a painkiller, it would work to reduce our pain. We really wouldn't get the euphoria from it. We would stop taking it. We would go about our merry way. But about 8% of individuals, when they take these, they will experience euphoria right away and not be able to stop. So someone may take a pill that's given to them by a physician and discover that they like the way it makes them feel and keep taking them long after the painful syndrome has gone away. So these are individuals who may have started with a pain disorder. There's no real test you can do to determine if someone's going to become dependent. Take them and over time develop a problem with them that they can't stop taking. So when we think about the risk factors, Dana's talked about a number of them. But one of the things that we have to think about is that when it comes to something known as opium, which comes from a poppy, and you slice the side of the poppy, and it's been known for about 7,000 to 10,000 years in different texts that it's been useful as a medication. If you take that sap and you dry it, you get this black-looking material that you can then turn into substances. And so opium was used for thousands of years until the 1800s, when the first synthetic opiate was called morphine, was derived from this poppy juice. And then following that was codeine. And then around the 1880s was heroin. So morphine was first used in the Crimean and the Civil War as a painkiller. It was the first time in human history that we were able to give this drug to people who'd been injured on the battlefield as a pain medication. In the 1880s, after the Civil War, chemists took morphine and played around with it a little bit to create this substance called heroin. It used to have an E on the end because it was thought to be a really good cough medicine for people to take against tuberculosis, because in the 1880s and until the 1940s, there were no antibiotics, so people would cough all the time. They'd be given heroin. What happened is that after the Civil War, you had a lot of people who were maimed and injured, who were amputated, and they became regular users of morphine. So you had the first group of intravenous users, because the hypodermic needle was developed around that time, who were using morphine intravenously for the treatment of pain. And in the process, some of them became chronically dependent on it. And when heroin became available as a liquid, some of those folks decided that they were going to inject it. And when you inject heroin, the effect is very different. Because when you take morphine and you inject it into the body, it crosses what we call the blood-brain barrier. So it gets into the spinal cord and travels to the brain relatively quickly. When you use heroin the same way, you get the effect in about 10 seconds. So the difference between heroin from all the other opiates, morphine, oxycodone, all the other synthesized, is that heroin gets into the brain within 10 seconds. And when it gets into the brain, it causes the reaction at this part of the brain, the ventral tegmental area, to release tremendous amounts of dopamine. So the amount of euphoria that people get is astounding. And the problem with heroin is that it doesn't stay very long at the receptor. So when people inject it, it stays for about 30, 40 minutes, and its action begins to fade. And so over time, people have to use heroin multiple times a day to get the same effect. So just to back up for a minute, you started out with a regular painkiller that was designed to treat pain in people who've had injuries of some sort. You end up with pharmaceutical industry trying to come up with a brilliant idea for the treatment of cough. That medication gets diverted by individuals who are injecting morphine, and in a number of years, you suddenly had, in some ways, an epidemic of heroin addiction in the 1900s. So there are many stories about, throughout the United States, cities being, as they call, littered with people who were using heroin intravenously And in 1914, Congress passed a law that outlawed heroin for sale by by pharmacists and by doctors could no longer prescribe it. So if you were a heroin user at that time, you could go legitimately to any pharmacy, buy a bottle of heroin and inject it. You could get needles, you could buy them from Sears and Roebuck. And so you had a natural environment that was opiate users. Since that time, there have been other pills that have been developed for the treatment of pain. And so someone may go to an MD and get painkillers and take them for pain. Someone may use heroin that they buy from a dealer and inject it. Someone may be getting painkillers initially and develop problems with that and end up all at the same pathway physically in the body. So the body doesn't really care if it's oral morphine or intravenous heroin or Percocet or Oxycontin in terms of the effect on the body, except for the fact that heroin, when you inject it, gets in the brain much faster than any of the other opioids. So when you have this, it doesn't matter if you got a prescription, if you bought it on the street, you can end up at the same place with an opiate use disorder. So from 1914 until 1964, there was no treatment in the United States for anybody who was addicted to opiates. And what happened is people were incarcerated by and large, because if you couldn't get it legally, you had to get it illegally, and therefore you were made a criminal. So most people had no treatment, and much of what you still hear today is from this abstinence model where people should just stop using. But what we know over time is that if you use opiates on a regular basis, especially heroin, you change the way that the cells in the brain work and you change the way the receptors work. And even though you think people should be able to stop on their own, they can't despite their best efforts. So we actually try not to use the word addiction anymore. With the DSM-5, it's opiate use disorders, mild, moderate, and severe. And when you have people that have severe opioid use disorders, most likely they're having difficulties with one of these drugs on this list. So we're going to talk a little bit about treatment and why treatment works, because people really, for the most part, have great difficulty stopping on their own. You have this in the book, The Effects of Opioids. They're used as analgesics. They can cause a lot of positive things. They can also cause a lot of negative things. And this is some of the symptoms that people have when they go through opiate withdrawal. So what you see is that people who begin to use heroin begin to use it in the beginning. They get high. They feel euphoric. Their pupils get very small. They feel drowsy, and they like that feeling. And then they continue to do that over time. And then over a series of weeks to months, the same dose doesn't work anymore. They've developed tolerance, and they need more and more for the same effect. And so now they continue to use to keep from being sick. And people who are sick from opiate withdrawal, they have runny noses, runny eyes, diarrhea, vomiting, chills, shakes. They look like they have the flu, and they can be really, really sick. And it's that constellation of symptoms that keeps people using so they don't feel sick. Like if you have the flu, you're in the pharmacy. What can I take to make the flu go away? If you're an opiate user, where can I buy my next set of doses so that I'm not sick? And so if someone's sick and they take some heroin or take some oxycodone, it makes the sickness go away temporarily. So when we finally see people who decide to come into treatment, they've been using for months, and they're no longer getting high on that curve. They're just trying to keep from feeling sick. So in the 1960s, because of an epidemic of heroin deaths in New York City, Vincent Dole, who was a physician that was well-renowned, was asked by the New York Department of Health to look into what alternatives are there to heroin users as far as treatment, because no treatment had been found to be effective. So what was discovered is that a chemical called methadone, which was an alternative to morphine in the 1930s that was developed, given once a day to people that were heroin users, for whatever reason, stabilized people from using, because the difference between heroin and methadone is that heroin is very short-acting but gives a lot of effect. Methadone is very slow-acting with not much effect. So methadone actually works as a blocker. When I go back to that receptor in the brain where the endorphin went to, okay, that causes this epinephrine to be released, that stress response, if you use heroin, we'll call it OH, consistently, you begin to set up more receptors because you've developed tolerance. If you add methadone, it essentially sits in this receptor for 24 hours and blocks the effects of heroin. So if someone gets put on methadone and we start them slowly and we raise the dose, it's a medical procedure, and then they try to use heroin, the heroin cannot displace the methadone. So people suddenly realize they can't really have the same effect. Even though they might keep trying to use behaviorally, they like the needle, they like the buying, they're in the subculture of using, they're blocked from the effects. And so methadone was shown to be highly effective in the treatment of opiate dependence to the point that in the 1970s, methadone clinics were established in the United States. If you remember when Governor Dean was our governor, he was resistant to the use of methadone in Vermont. And finally, in 2000, we became one of the last 8 states in the United States to have methadone clinics. There are still 3 in the United States that have no methadone clinics. Because one of the problems with methadone is that you have to go every day and get a dose. Because if you take too much, or you divert it, or you run into difficulties, someone who's not opiate tolerant can take it and potentially have a bad reaction. So it's pretty tightly regulated. And think about, having to get up every day and go to the clinic and get a dose until you're no longer testing positive. We'll finally give you some opportunity for taking doses out of the clinic, but it takes people a while to get there. And so because of that, because of the drug methadone, there was still a lot of resistance among users of heroin in the United States to go into treatment. It takes some effort to get up every day and to go into treatment. So an alternative to that was studied. We actually did a lot of studies at the University of Vermont of a second drug called buprenorphine. And the reason that buprenorphine was studied is that during the HIV epidemic in the 80s, there were so many people that were getting HIV, late 80s, 90s, that from injection drug use, that an alternative to methadone was sought out so that more people could gain access to treatment. And the idea was to find a second medication that was potentially safer than methadone to use so that you could expand treatment. So the difference between these two medicines, has everybody heard of methadone? Has everybody heard of buprenorphine? It's known as Suboxone, Subutex, that's the trade name. So the difference between the two is that, and this is a pharmacological effect, is that we have what are called agonist drugs. So agonist drugs are those drugs that give you full effect. So morphine, heroin, methadone, oxycodone, all of those are full agonists. So the more the dose goes up, the more effect you have. And the problem with opiates is that the reason that people overdose and die is that if you take too much opiate and you're not used to it, it slows your breathing down to the point where you stop breathing. Anybody who's on chronic opiate therapy, normally we breathe about 16 to 20 times a minute. People on opiate therapy can breathe as shallow as 8 to 10 times a minute. So when you take more and more and more, you suppress your breathing so that people actually go into respiratory arrest. And the new medication that's being used by emergency responders called Narcan or Naltrexone reverses that effect because it's an antagonist. So it kicks all the opiate off the brain so suddenly people can breathe again. So because methadone's a full agonist, it's risky in some cases. So buprenorphine is a partial agonist, meaning you can take a lot of buprenorphine and at the initial curve, the initial rise of the line is the buprenorphine effect, you get full effect, and then it levels off, and it's called a partial agonist. And what that means is that it's theoretically impossible for someone to overdose on buprenorphine, so that you can take large amounts of it, or if people were to divert it, it would go to the street and individuals would take it. The safety profile is much, much safer. So because of that, the federal government decided they wanted to change the law that was written in 1914 and reverse the prohibition on doctors treating opiate use disorders in their office, because up until the year 2000, if someone came to see me who was using heroin, I could not write them a prescription for methadone. I would lose my license. So they reversed that to say that any doctor who takes a training to prescribe buprenorphine can prescribe buprenorphine in the office, and we can treat this as a chronic disease as opposed to some criminal activity. And so buprenorphine became available in Vermont. has been the leader in the United States in the amount of buprenorphine prescribed. We have, since it was introduced, been the #1 state in the country for prescribing buprenorphine, the number of doctors who have waivers, and the total number of pills dispensed per capita, because our state has done a tremendous job in promoting buprenorphine. Partially that's because there are 6 methadone clinics in the state. I work in one in Newport, St. Johnsbury, and Burlington, but if you live in St. Albans, you got to drive to get to a clinic every day. If your doctor prescribes Suboxone in the office in St. Albans, you go in, you get your prescription like Dr. Holmes did, you walk out the door, you have a life. You can work, you can take care of your children, you can deal with all the different aspects of it. So for many people in Vermont, buprenorphine is a much better option because of the rural nature of the state. If you're in the Bronx, you know, there might be 50 methadone clinics in the Bronx. You can walk down the street and go to your methadone clinic. It's not as though travel is an issue. So the advantages of buprenorphine is that you don't have the negative side effects that methadone has in terms of sedation and potential for overdose. And since it was introduced in 2000, there are now about 380,000 people in the United States on buprenorphine and about 350,000 people on methadone. Treatment has expanded tremendously, and buprenorphine also works as a blocker. So we at the Chittenden, all the clinics in the state, all the hubs as we call them, prescribe both methadone and buprenorphine, and doctors can also prescribe buprenorphine to treat heroin or any kind of opiate use in their office. Just going to mention one other drug, and that is Naltrexone. Naltrexone is a blocker, complete blocker, different than buprenorphine or methadone, in that when you take it and you take any opiates, you have no effect, and it can be taken orally or by an injection. This drug has limited usefulness. It also works for alcohol use disorders because many people do not want to come off of methadone or come off of buprenorphine and go on to naltrexone because it takes some effort to wean one off. So the group that seems to have the greatest success with naltrexone are people who are coming out of correctional facilities, people who have been long-term stable and have weaned off successfully and want to go on it. But this has limited effectiveness, although in theory you would think, why wouldn't everybody be on it? It just seems to not be well adopted by the use population. And then I did mention Narcan. Narcan is widely available around the country now to reverse an overdose in anybody who's used too many opioids. How much time do I have? A minute? I just want to go back and highlight on a couple things. So one of the reasons that we think about treatment in general is that if you look at, and I'm a primary care physician, I work at the community health center in addition to working for the Howard Center, and this week alone I had 2 medical students with me, and I said to them, I've got diabetics that do much worse than people who are on buprenorphine in my office, because if you look at, and this was a slide from 2000, if you look at people that have chronic illnesses, diabetes, hypertension, and asthma, and you look at their average blood sugar, you look at their blood pressure, you look at the way that they're breathing, 60 to 80% of people who have asthma don't take their medication on a regular basis, and their level of breathing is not normal. 50% of people's blood pressure is not where it should be, and probably 50% of people with diabetes is not where it should be, because there's no meter that goes off that says my blood pressure's high. But when you have an opiate use disorder and you don't take your buprenorphine or you don't take your methadone, you feel ill. And so the compliance rate is as good with this disease as it is with these diseases. And I would argue people are sometimes more motivated. However, don't mistake that diabetes can also be a disorder of an addiction. People can overeat, they cannot take care of themselves, they can crave all kinds of foods. And so in some ways, smokers who develop high blood pressure, it's almost like there's a spectrum of human behavior that just decides what drug they're going to use and what disease they're going to end up with. So we shouldn't confuse the fact that treating alcohol and drug users in a medical office is as effective as treating these other disorders. And so that was the idea behind putting buprenorphine in doctors' offices so it could be treated like any other chronic disease. And the 2 other things that I just wanted to point out is that if people are not in treatment, if you look at someone who decides they don't want to get treated for their heroin use or they get involuntarily discharged, the rate of death is tremendous. And so when you look at what you'd expect, it's 0.5%. You have 8 to 20 times increased death rates in people that are not treated. So even though we think that people who use heroin who aren't coming into treatment, we want those people to come into treatment because the risk of overdose, the risk of all the other things that they can die from goes up significantly. And when we at the clinic have to discharge somebody, say for bad behavior or some violation, we worry about what's going to happen to them. So we really try to hold on to people as long as we can because heroin addiction has a high risk of overdose and death. And the other thing is crime rates go down significantly when you treat people because people have to commit crimes. Although heroin is so cheap now, it's almost as though people don't have to commit crimes anymore. You can buy it for $5 or $10 a bag. It used to be $40 a bag or a dose. But crime rates are very, very high in areas with no treatment. And once you bring people into treatment, they no longer have to deal or steal. And so we see a direct social benefit from that. So I'm going to stop now and turn it back over to Dana. Oh, and if you have questions, I'll answer them after.
Thanks, John. There's so much more we could be telling you. It's so hard. We're both so enthusiastic about this topic. I wanted to say something that I neglected to say earlier on, and I do want to mention, because it's come up before in some other presentations I've done, is John was mentioning there is a subset of the population who responds with a more euphoric response to the use of opiates than in general. So while I was describing earlier some of the risk and vulnerability factors, those are not present in every single case. Sometimes it's just some of this physical predisposition. So John mentioned those people who may be prescribed a pain medicine by their physician who develop tolerance and have difficulty getting off. There are other people who may be just going through a normal stage of life issue. Think of adolescence, and I don't know if there are any adolescents here tonight, but I think those of us who remember being an adolescent would never want to go back there again. I know I wouldn't. So you take this experimentation it's also a norm for that age group. People's brains, their prefrontal cortex is not fully matured until we're about 24, 25 years old. So kids take risks that they really, just don't have the executive functioning to assess well. So you can get a kid, and we hear these stories way too often. My son was an athlete. He was popular. He did well in school. Everybody liked him. He got addicted to heroin, and he died. Came from great families. So I just wanted to make that point, that this can happen to anyone. And in fact, friends of mine, I have friends with sons, nieces, etc., who have come through our doors. So I truly know that it can be anybody. So what do? So John talked about medication-assisted treatment, and that is one of the options available to us. We find with people with a severe opioid use disorder, this is probably our best option. But there are other options out there. There are recovery supports and self-help, such as AA, NA, and we have throughout the state turning point centers where it's a peer recovery model. It can be very effective, and we always recommend the people who we're serving seek these additional services, because our hope is that they're not always going to need us, that they'll have a natural support system. If you look at a continuum of intensity of service, outpatient services would be the next highest level, where you're working with a trained therapist. Usually in our work, it's a master's degree person, the degree in social work, counseling, psychology. And you may come in for intensive outpatient programming, which is several times a week for several hours, or it may be a group or an individual session once a week. Some people who need to take a break from their environment don't have a lot of supports at home, have high risk for relapse, may benefit from a stay in residential treatment. But medication-assisted treatment is a long-term treatment, and for some people it's for life. So there's this, trying not to step on the wires here. Let's see, this graph just shows over the course of, about 10 years, how many people were, this comes from the state of Vermont database, people who were treated for opiate use by fiscal year in the state of Vermont. And you can see up until 13, the blue line, the other opioids, the synthetic opiates, these are the prescription pills. The highest rate of admission were these other opioids. Heroin, you can see, is making an upsurge. And this is, these are old data here, but it's illustrative. So what the state just came up, and I think John was, correct me if I'm wrong, but I think instrumental in helping conceive of the model that we've adopted, whereby we have what we call these opioid treatment programs, also known as hubs, which are the highest level of care. They're the most highly regulated, and we've talked about earlier, this is where people can get methadone and buprenorphine, and if we will be beginning to use Naltrexone if anybody is willing to sign up for it. Again, highly regulated, you have to go through a period of time with attendance, no behavioral problems, negative urine drug tests. So eventually you're able to take medication home, but this happens over a period of time. We offer this to people who have more complex presentations. They're co-occurring issues, either medical or mental health, also maybe housing, maybe problems with health insurance, transportation, et cetera, et cetera. The other idea is that spinning out from this hub would be these spokes, which would be physician practices, either primary care or other specialty practices, where people can go where their needs are not as intense. So they can receive a prescription, where in our program, people come either daily or they come to us and pick up take-home medication. It's put in a lockbox. You don't have a lockbox, you don't take it home. We try to prevent diversion by having random callbacks, so people are responsible for coming in 6 times a year, unbeknownst to them, till midnight the night before. They have to show up. They have to have all their bottles or their strips of buprenorphine in order, no signs of tampering, et cetera, et cetera. With the spoke, people receive a prescription the way you go get amoxicillin or something, you go get it at the pharmacy and you take it home. A lot of physicians, however, were very nervous about doing this in their offices. After the initial implementation or introduction of buprenorphine, you've probably heard about a lot of problems with diversion, and that's because systems hadn't been set up in place to more carefully monitor and provide support to physicians so they know what good practice was. How do you work with someone who has an addiction, who may relapse, who may need additional supports? The other problem at the time was that the Chittenden Clinic was the only OTP in the state of Vermont, and we started in 2002. Was that 2002? And it wasn't until sometime in 2013, I think, that other programs. No, well, when did BART come online? 2005. So that was in the Northeast Kingdom, and eventually by 2004, we now have 5 of these hubs. So physicians became nervous about how do I, so anyway, to back up, because there's only very little access to an OTP, people who really needed a higher level of care were getting treatment in the community. So some physicians became very worried about how do I manage this. So the state has come up with a model that provides support to physicians. Whoops, what happened? Oh, just a blip, I think. Nope. Okay, so the Blueprint for Health, what it did was it optimized a really good match, a federal Medicaid for state match that was available through the Affordable Care Act for a period of 3 years. And they said, let's see, what do you need? They went around to physicians' offices. What do you need to support you in prescribing buprenorphine on an outpatient basis? They said, we need a nurse to help us monitor. We need a licensed clinician to help make sure people are getting treatment. So this just shows over, it starts at 2013 in the first quarter, and then follows it up to third quarter, which would be March 30th of this year, 15. This, you can see the increase in the number of, what says MAT FTE hired, those are the nurses and the clinicians. And you can see that there is beginning to see an increase in providers signing on to do this, and the number of patients receiving treatment in these spokes is also increased. We also see here, what are we looking at? Total people served in the hub, waiting over time. From January of 14, you can see there was an increase to almost, whatever that was, to like 2,750. Here's something that shows the various hubs that we have and how the admissions have developed over time. So you can see here in Chittenden County, we have the largest census. We have a capacity, when I say capacity, I'm basing it on physical office spaces. Basically, that's one of our limiting factors. But we potentially can serve 950 patients. And I think it was in July, I might be getting my years mixed up, July of 13, we had about 520 patients. By December of 14, we hit our 950 mark. So that's just another pretty picture. And this just gives the number of, I don't know what this was. This was as of June 30th, the current census in these various counties. So I think this is all I have for slides. But this is just a bit of information about how you could sign out that film I was talking about, The Hungry Heart. But I think because of time that we'd like to turn it over to questions. And Denise, how do you want to manage that with the microphones? And
So we can all talk at once.
yeah, but maybe if the people in the audience.
Oh, hello? Yep.
Just was curious to know if you had any idea of how many people have a substance use disorder but aren't on the wait list because they're not at the point of seeking treatment. Any sense for that?
So they do this, the federal government does this call every couple of years where they call people the household survey, and they determine that something about 94% of people who meet criteria for treatment have not even, 94% of people who meet criteria haven't even tried to get into treatment. So in Vermont, right now we have in the Burlington area, our waiting list active is 261, but the universe basically abhors a vacuum. So anytime we open up the doors, if we were to, quote, eliminate 260 people on the waiting list and bring them in, there'd be another 260 to take the place. There's probably about, in Chittenden County, 3,000 to 5,000 more people who need some kind of help around opiate use. In the Northeast Kingdom, we've gotten down to, in Newport for a little bit of time, we had no waiting list, and so then people would just call us. And I'm always amazed in Newport, Vermont, like how many people, we have about, between the two, we have about 560 people in treatment between St. Johnsbury and Newport, and we get calls all the time. So you'd think very rural area, you kind of dried up the population, people are in treatment. It always seems to be new people coming in. So what happens is that when someone sees that their friend got in, they then call, because if it's a long wait, you don't even bother calling for treatment because you know the wait is too long. So there's perception in the community. So with open enrollment, if it ever existed, people would just have open access to treatment like they would for any other disease. And so we need a whole lot more capacity to serve all the people that need treatment. Yeah.
Can you talk about inside the correctional system in Vermont, what kind of treatment is and isn't available to people, and then also on release, like coming out into the community, what that picture looks like?
That's a really good question. Maybe I might turn this over to John because he can speak to he and some of the other members of our staff work in our Safe Recovery Program. We're really involved in some of the legislation that's happened recently that's loosened up some of the rules that Department of Corrections has about treating people who are incarcerated. So would you be willing to speak to that?
So in terms of people that are currently in treatment for heroin or any opiate user who's in treatment that goes to either Northwestern Correctional or the Chittenden County Correctional Facility, we now have up to 90 days of treatment. So if we know that you have a long-term sentence of greater than 6 months, the correctional facilities will ask for a 30-day taper. But if it's less than 6 months, they're going to allow us to keep people in treatment for up to 90 days. So that means that we can provide methadone. The Department of Corrections provides the buprenorphine, and they have not been as rigorous in the 90-day rule. But the initial, the newer legislation points to this as a pilot project for 90 days. Any of the other correctional facilities in the state, if you're in treatment, you can be treated for up to 30 days. It used to be you walked in the door, you came off your medication 8 or 9 years ago. So there's been a tremendous acceptance in the Department of Corrections that many, many people need treatment. The Department of Corrections still says that buprenorphine is the #1 contraband in correctional facilities. People bring it in all the time, and the argument is that so many people are in there for opiate use disorders, we should really do a greater job of treating. The most recent grant that came from SAMHSA, the SAMHSA grants of $1 million a year, specifically targets people who are in DOC custody in terms of trying to help prioritize when they come out of corrections for treatment. And anybody that has gone into corrections from any of the facilities that I'm involved with, the hubs that I'm involved with, if they went into corrections and they got tapered off because of time, when they are ready to come out, we generally take them back into treatment, and we want to take them as soon as they get out, because the highest risk time for overdose and death is upon release, because people have lost their tolerance. So we try to get them in as soon as possible. Safe Recovery, Tom, Dalton, and Michelle, they go into the facilities and they ask people who might want treatment. They sign them up. They kind of keep a running wait list. But there's still no concerted effort from the day people walk in to have planning if they're not in treatment, because our waiting lists are so long. It's hard to say we're going to take you coming out of prison and bring you into treatment over someone else who's been on the waiting list for 6 months. So we don't yet have that open access. I will say that in terms of states around the country, Vermont is one of the most liberal when it comes to treating people who are incarcerated, because most states in the United States, you walk into a jail facility, you are off your medication, they're not even going to talk to you about it. So we are trying at least to try to extend that. And the next, I think, iteration of this, because of this project, is to see how well this 90-day thing is working and see if we can keep people on their medication for up to a year. So the goal is to continuously extend the duration of time that people are in treatment, because they're less likely to use heroin or other drugs while they're incarcerated. So that's what I can talk to as far as opiates are concerned. Was there something else you wanted to know about that?
My follow-up question, you kind of got at it a little bit, but just to be really explicit. So if you walk in the door, you're on that waiting list, or you're not on that waiting list because you know it's so long. I mean, you're basically like, you're just in there, you're going through withdrawal.
Yeah, so if you're not in treatment and you're a heroin user and you go into jail, they will try to treat your symptoms. They will use clonidine or others, but there's no formal withdrawal process with methadone or buprenorphine or maintenance while you're in jail if you're not currently in treatment. So they don't start treatment while you're incarcerated. No, go ahead. This is a big topic because how do people end up in jail? They end up in jail for stealing and dealing for drugs. And so if you don't treat it, it's a revolving door.
I mean, is there any correlation between that withdrawal experience and like how difficult that is and the negative associations maybe with that and kind of return to heroin use once?
You mean, do people learn when they go through withdrawal they shouldn't do it again? No. No.
No, I mean kind of the opposite, that they're like, ooh, don't want to go through that withdrawal experience again. That was terrible. Didn't have the supports in place.
Yeah, I wish it was
keep
this.
using on the other side.
They oftentimes will continue to use in jail. I mean, I hear stories of people spending large amounts of money, even while they're incarcerated, to buy methadone, to buy heroin, to buy buprenorphine while they're in jail, so they don't get sick. And there are some people who maintain themselves their entire time they've been in jail with some kind of substitute therapy for however means they do. Yeah, those are good.
Are there programs for parents? Not all addicts are single people without children to take care of. What kind of supports are in place for those people who are actively parenting young children or older youth?
I might need to ask you to clarify that question. Are you asking what supports are there for parents who are in treatment?
Who are in treatment, yes.
Oh, okay. All right. Well, there are a number of them. Within our own program at the Chittenden Clinic, we have I'm going to pick on someone in the audience. Chelsea, what's the name of that group? Your
Parenting and Recovery Play Group.
Parenting and Recovery Play Group that my lovely colleague there developed. But it was a group where parents and their young children could come. It was very therapeutic. The staff would model how to interact with children in a way that was positive. There's another program called Rocking Horse Circle Support Group. It's been around for, I'm not sure, maybe 15 years or so. It's offered throughout the state. It's for women and their children, provides some supports. The Lund Family Center does a lot of work with parenting people, not just the women. John, maybe you know of some other opportunities? Was that?
Well, it's a really interesting question because actually the reason that the first methadone clinic started was because of pregnant women. Because the first set of women that were pregnant that were opiate users, that was the genesis of the first clinic. And so we have always had a much higher proportion compared to many clinics in the United States of parenting women and their partners in treatment. So we have had a philosophy of really trying to support parents. We have this monthly meeting called the CHARM Group, which talks about how to support women during their pregnancy and afterwards. UVM has a great NeoMed program to support women, but what happens is when the baby time is over and you've got 2 and 3 and 4-year-olds, those supports tend to fade away. And so I think, doesn't Bruce do something with fathers? Isn't there a father group also? Or there are other supports.
We have it at times offered.
Supports for that. And we used to have mothers on methadone. We used to have a support group at the clinic where women would get together and talk about it. So we really try to enhance anything we can in that regard. Yeah.
Just a follow-up to that. I work at the university in partnership with the Department for Children and Families, and in less than a year, out-of-home placements have increased to almost 40% because of drug use, and there's just not capacity to, I hear that there's some connectivity if people are already in treatment, and just wondering how as a community to reach those people who aren't in treatment yet, because those are the children and youth that are getting harmed because of their parents.
Well, this SAMHSA grant that I mentioned targeted 2 populations. One was corrections and one was people under the purview of DCF. And so the hope is that we can do a little bit more in terms of increasing access. Yeah.
And also, there are other programs within the Howard Center that are focused specifically on children and their families, not necessarily related to people with opiate use disorders. And then there are a number of other organizations as well that serve families.
With the rising number of people in treatment, I'm just wondering about what the termination of that treatment looks like, and kind of are there any formalized processes in thinking about the end of methadone use or the Suboxone use?
I think this is one of the things that may be difficult for people to wrap their heads around, that for many, many people, this may be a lifelong treatment. In terms of levels of care, as I mentioned before, stepping down from the intensity of a hub to a spoke is certainly progress into having a life that revolves less around taking care of your addiction. There are people who do want to get off of medication-assisted treatment, and that conversation, if we're working with someone who's been very stable for a very long time, it's a conversation that is introduced as an option. We never would push anybody in that direction. But there are things that we look at in terms of what the prognosis would be. Is the person working, or are they involved in raising a family? Do they have social supports? Have they had a long period of abstinence from illicit use? Are they not engaged in any kind of criminal behavior? So there are some really fundamental, foundational pieces that should be in place before we would encourage someone to decide to discharge.
I wanted to thank you guys for the community outreach. I think it's a great idea. And I realize Howard Center is focused on treatment. When you guys go home at night and have dinner with your families or sit around the water cooler, why is there 600 people between St. Jay and Newport or whatever the stat was that are having this problem, and what's the answer? How do you stop it?
Well, I think you missed the first part, which is that the human brain is wired for novelty. And all humans, for time immemorial, have experimented. And if you pick the wrong substance to experiment with, and you got the right brain and it links in there, it's practically impossible to do anything about that linkage. And so what it comes down to is, and as the film pointed out, we live in a society that wants instant gratification. And I'm astounded, though, when I go to the Northeast Kingdom, I think, why aren't people fishing and hunting, bowling, and reading? What is it with heroin? How does it happen? And I don't have another explanation. Sometimes it just happens. People take substances, and unfortunately, they like the way it makes them feel, and it's really hard for them to stop. And so, will it ever go away? Probably not. Maybe someday we'll have a little electrode planted in there that makes our dopamine go off, and we just hit it all the time, and we feel good. And I'm serious. This is what I think about, is how come no matter how many people you treat, there's always more people to treat. It's like it never goes away. And I don't have an explanation for why that is. Is that anything close to what you were hoping to hear?
Oh, of course not. But whether it's alcohol for eons, right? There's always something. But to look around at your neighbors and see people no longer productive, and the collective drain on resources in the society and all those things, what would cause somebody to need it? I guess once you're there, it's too late, right, is what I'm hearing. But why go there?
You think, why heroin? Everybody knows heroin's not good for you. Why do people buy cigarettes? It's just novelty. They think, it's not going to happen to me. I'm going to take it, but I'm not going to get addicted. Or it's a pill, and a doctor prescribed it. It's got to be safe.
Okay, is heroin the result or the cause? Are the prescription drugs and their availability, is that the leader?
Heroin was around a lot longer than any prescription drug.
Yeah, I think that without backtracking too much, because this was the first one. It's a very complicated overlay of these human tendency, seek pleasure, avoid pain. That's the way we're wired. And then you overlay that onto that opportunity for whatever substance it is. You overlay, or that's overlaid upon all kinds of social, psychological, factors that create vulnerability. And I think this is part of the human condition. And I think the answers in terms of prevention are very large policy issues that are probably more than, you don't want to get me going on that because we'd be here all night. So thank you. I think there's a few other questions. And
could you talk about marijuana, legalizing marijuana, and how that ties into all of this? Or is there no
You have
link?
to come next week for that talk.
Really, because, you know, it used to be marijuana is a gateway drug. And I don't know if people don't think that anymore. I'm just
Tobacco
curious.
is the gateway drug. Tobacco is the gateway drug. 99.5% of all the people in our opiate treatment programs are tobacco users. About 25% of marijuana users. Tobacco is the most reinforcing addictive substance that a human can ingest. Once you start, you're going to continue to smoke. And it's one of the hardest, the last drug. We've had myriad of smoking. We've researched studies in heroin users, and it's really, really, really hard to get people to stop using that. So the thing is that it's not a gateway drug, so to speak, marijuana. But we have receptors for marijuana. You become physically dependent to it, and it's like anything. Do you want to have a line in the sand that says, my drugs are okay, but yours aren't? And so you pick and choose which ones and who's legislating and who's getting paid. So you could think of a society where everything is legalized and you just offer treatment on demand. You know, whether or not that's an option for the United States, I don't think so, because we like to play cops and robbers. We like to find people and chase them around. But the fact remains that, you know, you can be as wired as you want on any kind of substance, whether it's legal or not. And so the question is, do you want to spend a lot of money trying to keep people from doing which is their natural inclination? That's all I'm saying about that. And I've got a lawyer in the room to back me up. But it's a great question. Yes.
I have a comment, actually. If we work off a medical model of addiction, which is what we're doing here, for me the most enlightening slide was the comparison to medication compliance for high blood pressure, for diabetes, and I think that also answers your question in front of me. I'm sorry, I don't know your name. But really the issue is, how many people do we know that overeating is not good for them, that know what good food looks like, that still go to McDonald's, that know that high blood pressure can get them to stroke out and live a miserable life, but that still don't exercise. And so that if we look at addiction as a medical model, the first thing that would behoove us would be more compassion, because there is still that judgment, that moralistic sense that people could if only they wanted to, but we don't apply that in the same way to the way we go overboard in our own behaviors.
Questions down here.
I have a question. How many physicians are there in, let's say, the Burlington area, Colchester, Essex, that would prescribe Suboxone?
I mean, that are currently?
Right.
I think there's one in Essex. I think there's one in
No, I can. It's probably somewhere on the order of 25.
But they
Chittenden County, about 25.
But not specifically in those two cities, just in total.
Will there be more in the future?
Yes.
Okay.
It's not. I'm not sure if there was more to that question. It's not happening fast enough in my book.
It isn't happening fast enough.
It's not happening fast enough, and that part of what this part of our mission in educating the public is to destigmatize this illness and to encourage people to have more compassion and not have this not in my backyard kind of attitude, and to help dispel some of the myths and the fears. So it's not happening fast enough. I go on record.
It's true, because I was talking to my physician, because I had a physical just recently, and she knows about the problem, and she had mentioned that she had her neighbor across the street, a young adult in his late 20s, pass away from an overdose. So she said it's everywhere, and there isn't enough out there for treatment. and there's more like a demand, so there's all these crimes being done to supply the demand.
You know, I definitely have a bias here. I believe it's a moral imperative. If you are a physician and you have the ability to take on a portion of this work. But that's my opinion, and part of the work the state is doing is to try to, by this spoke model with these additional staff, the staffing model, to provide some support to these physician practices so that they aren't so afraid.
Right. Thank you.
Sure. Denise, I think there's some up front that have been waiting.
I just wanted to know, do people pay for the methadone, or how is that funded?
No, it's paid for by insurance.
Okay.
There are self-pay models in some places around the state. In fact, many places in the United States, insurance does not pay for methadone treatment, so people pay out of pocket. Some states, Medicaid will not cover it. Medicare typically covers small portions of it, and all commercial insurances do pay for treatment.
So in comparison to what heroin costs, is it, if somebody had to pay out of pocket, would it be a lot more than?
You know, it's a great calculus because most heroin users have what's called temporal discounting, where they're just thinking about what I need right now, and the idea about saving $30 a day and spending $60 a week, it doesn't work like that because you're always somehow able to figure out how to get the heroin, and I never quite get the calculation when you kind of add it all up. But for some reason, to pay for treatment is usually more costly than using every day for some people in their mind.
In their mind.
The economics are certainly there to support treatment being very cheap. I mean, methadone is about 0.4 of a cent per milligram. So a 100 milligram dose, which is a standard dose, is 40 cents a day. But it costs a heck of a lot more to deliver it. But the cost of medicine is not the issue. It's all the administrative stuff that goes around it.
Yeah.
My question is, what does the most recent research say about all the babies that are being born addicted?
So the research shows that babies who are born to moms who are exposed to opiates has been around since the 1970s. And what you see is that if the mother's pregnancy is healthy because she's no longer using heroin, then the baby is going to be very healthy because mom's got proper nutrition. In fact, Marge Meyer, who's one of the obstetricians at UVM, who started this program with me 12 years ago, has published a lot of data showing that in babies who are born to moms who are maintaining methadone, buprenorphine, birth weights are up. Premature deliveries are practically non-existent. Maternal health, child health is excellent. When you track the kids through school, you don't see any difference in terms of age-matched cohorts in babies who are born to moms who receive treatment. In babies born to moms who don't receive treatment, much smaller birth weights, less healthy, chaotic environments, often Department of Children and Family involved, poor school performance. So if you take the social part of it out, you really see no difference. In fact, the babies that I took care of who are now 13 years old, many of them are like straight A students in school, excelling, doing really well, because their mothers no longer were ravaged by the disease and they were able to provide a healthy home for the kids. So we know that maternal-child health in the beginning plays a key role in how these children do later on. They're at increased risk for the genetic disorder of addiction because they might have one or two parents, they've inherited a risk, but because mom and dad know about this, they can do a little bit more planning around it than perhaps their parents did in their chaotic environment. So it sort of changes generational culture by treating people who've maybe the first time in 10 generations have not used. You know, when you look at generational stuff, alcohol and morphine and all this stuff through the ages, it's essentially you're changing the culture of the family.
What about the actual follow-up question? What are the actual effects of the kids being born to
So opioid exposure per se is not necessarily harmful. Tobacco, super harmful, alcohol, super harmful, but opioids as drugs are safe in terms of they don't cause fetal defects, they don't cause developmental defects, and really what happens is that the fetus is exposed and needs to be treated at birth for any signs of withdrawal. And if you look at buprenorphine and methadone, we did what's called the mother study, and you can look that up. It was published in New England Journal of Medicine. It was a 6-site study, and we followed pregnancies on either buprenorphine and methadone and found that the safety profile of both was about equal. And so you have the initial birth is monitored closely, and then the kids are taken off and weaned off the medication. And we have a whole program at UVM called the NeoMed program that follows these babies for up to 2 years afterwards. So maternal effects, I mean, the effects of opioids on the fetus are relatively minimal compared to any other substance.
Go back to the prevention question. You know, so as a community, we're trying to tell people, lock up your drugs, turn back the drugs you don't need, asking doctors don't overprescribe, educating young people about developing brains. I mean, that prevention question, I was thinking kind of included all those sorts of things. Wondered if you could comment on those efforts, that community-wide things that can be done.
Yeah, there's a big effort on the state. I mean, we just had this unified pain committee that met 2 years ago. Commissioner Chen convened, and it rewrote the rules around prescribing. I mean, every doctor in the state has to be signed up for the prescription monitoring system. You're supposed to check it. There are guidelines when to check it, how to check it. There's 120 morphine equivalents. If you go above that, you have to have a review. So there's a lot of more checks and balances now than there were to try to prevent overprescribing and doctor shopping, which really doesn't exist to a large extent in Vermont compared to some states. But it's really just, again, educating that, you know, the treatment for every ill is not a pill. And so it's a whole sea change in the medical world, too, to sort of retrain us all about how to prescribe. Should we call it a night? Any other questions?
So with the Suboxone and the doctors having to get special training, I heard this, and I don't know if it's true or not. Is there a limit on the number of patients that they can see then also?
Yes. So when you get your waiver, it's the only substance that you need to have an additional waiver on your DEA license. You have to get what's called an X number. 8-hour training. You can do half and half. You can do some online and some in person. You can do it all online. Once you get that, you can prescribe for up to 30 individuals the first year, and you apply the DEA for a second waiver to treat up to 100. But there's a limit on 100 patients per physician in the United States. Nurse practitioners and physician assistants cannot prescribe, and there's certain regulations. But really, it's that you have to take the training, you're limited to the number of people, and you have to be able to refer for counseling. So that is, in fact, true. However, at the hub, there's no cap because we're operating on a different license. So we have 250 people on buprenorphine at the San Remo clinic because we don't have a cap because it's a different program.
Oh, we'll take one last question, and then...
My question is, if someone comes to the Howard Center who's been court-ordered to have a substance abuse assessment.
You mean to the Chittenden Clinic? Because we don't do
or
that.
just to one of our programs.
Yeah, 20 of your programs.
Okay.
How do you determine their substance use and their treatment?
There are a number of things we would do. There's a structured interview that we give that goes through these criteria, but we also do a very comprehensive evaluation. It's a psychosocial evaluation where we look at we take an extensive substance use history, but we also look at psychiatric issues, education, vocational stuff, medical, et cetera, et cetera. So it's a very in-depth evaluation. We also get a urine sample because surprisingly not everybody who's court-ordered thinks they have a problem.
Right.
So we want to get some objective verification whether or not there's anything in that person's system. We would, if the person allows us to, get collateral information to corroborate or support or get additional information. So we don't have enough time to go into it, but we look at a number of dimensions, and based on where people are in terms of risk and strength on these dimensions, such as their supportive environment, their motivation, their physical health, we'll make a recommendation for level of care, such as I was speaking about before, earlier on.
My concern comes with the fact that if they don't let you collaborate or talk to outside source, you're relying solely on self-report.
Right. So there may be somebody out there who's not treated, who doesn't get the level of care that they need.
Exactly.
Yep.
Okay.
Called denial, you know.
Yep.
Yeah.
Yep.
And again, a lot of people, it takes a lot of effort to get up every day and go to a clinic and get a dose. And for some people, it's just too much work.
Yeah.
You know?
So before everyone leaves, I just wanted to take this opportunity to thank you all for coming out in the evening. I never, once I get home from work, I never go out again. So I appreciate it. I appreciate your willingness to come and your curiosity to learn. So thank you.
I think it's on Dr. Lassie.
If people could do their feedback forms, we would really appreciate that.
Take a sack.
I know.